It's truly a pleasure to be talking to everyone today. I'm Greg Yanik from the University of Michigan Medical Center, and I'm direct the stem cell transplant program here at the University of Michigan. We have a great team here at the University of Michigan, but we also have a great team nationally that I work with. I've been proud of the work that pediatric oncologists across the country and world have done over the last 30, 40 years in terms of improving the survival rates for neuroblastoma. I finished my fellowship uh, at Cincinnati Children's Hospital in 1991. At the time that I finished my fellowship, the 3-year, what we call disease-free survival rates for children diagnosed with neuroblastoma was at best 20%. Here in April of 2025, if you look at our current modality of therapy, we're up to close to 60%. And in selected cases, it can be higher. Obviously, in selected cases, it can be a little lower. But we've literally not just doubled, but tripled the survival rates for our patients that are diagnosed with our children that are diagnosed with neuroblastoma just during my career. Here at the University of Michigan, I work closely with my oncology colleagues to serve as their arm for bone marrow transplant for children with neuroblastoma. I also direct our MIBG therapy program here at the University of Michigan. I've been integral to the neuroblastoma stem cell strategy group, first within the children's cancer group and then within the children's oncology group over the last 30 plus years, working with a number of talented investigators in helping to design many of the clinical trials that you as parents and your children may have been part of. It truly is a great team, and I've been blessed to have been a part of this entire team. When I look at the goals of stem cell transplant in high-risk neuroblastoma, I think of two goals. Where have we come from and where are we going to? The first goal is where we've come from. And from the late 1980s, 1990s to present, the goal of stem cell transplant was to serve as a platform for delivering high-dose chemotherapy to patients as, quote, consolidation after their initial several rounds of chemotherapy called induction. Where the goal is now, that I see potentially for stem cell transplant, is not to become just a platform for high-dose chemotherapy, but to become a platform for immunotherapy, to become a platform for novel approaches that we can take cells, stem cells, manipulate them, your own stem cells, use specific cells called CAR T cells or NK cells to then add a whole novel strategy on top of the entire transplant platform. Now, let me just go back then to the start. The initial transplants for neuroblastoma started in Europe and in North America in the 1980s. In the 1990s, a landmark trial was done. I still view it as one of the landmark clinical trials in all of neuroblastoma therapy. The trial was run by Kate Mathey. The trial was named CCG 3891. It was published in the New England Journal of Medicine. I believe it was 1997. And the way the trial ran was this. It was a fairly large trial also. It took children who had high-risk neuroblastoma. Everyone went through multiple courses of chemotherapy and induction, and then half the patients were randomized to receive 3 additional courses of chemotherapy, and the other half were randomized to receive a single bone marrow transplant. The survival rate for the patients that had the single bone marrow transplant was significantly higher than for those patients that just had the extended chemotherapy. For those children that underwent consolidation therapy with a single bone marrow transplant, the 3-year event-free survival or disease-free survival rate was 34%, compared to just over 20% for those children that just went on to get extended chemotherapy. It was on this landmark trial, CCG 3891, that bone marrow transplant truly became a foundation. A lot of people ask me, though, what were they really doing? I tend to view bone marrow transplant in the 1990s, 2000, 2010s, all the way up until now, as just a larger sledgehammer. If you think of it as follows, in fact, as a parent, if you're listening to this talk, Think of a ladder. Every rung on the ladder is a certain level of chemotherapy in terms of the intensity of chemotherapy. You can go up multiple rungs on this ladder, basically dose intensifying the chemotherapy. The chemotherapy that you currently get in the first two courses of induction therapy certainly within Children's Oncology Group, it's not low. It's several rungs on the ladder up. Courses 3, 4, and 5 of induction therapy within the COG model is even a rung or two higher. And then imagine transplant, where now you've gone up several rungs even higher above your induction level in terms of the amount of chemotherapy you're getting. What does that mean in English? What that means in English is that when you're up 3, 4, 5 rungs on the ladder, you get chemotherapy, the blood counts go down. They'll stay down for a week or two, and then they'll gradually come back up. When we dose intensify chemotherapy for transplant by going up several rungs on that ladder of intensity, now the blood counts will go down, but they'll never go down unless you literally rescue the body with your own stem cells. In essence, the way that transplant has been used for the last 30 years is as a platform to try to get rid of all the weeds in the lawn, not by individually plucking up the weeds with that little metal prong thing or by you spraying with Roundup, but by literally taking out the entire lawn and reseeding. The actual stem cell process itself, where we put the stem cells in, it doesn't do anything to treat the neuroblastoma. It's just a way of rescuing the marrow. And again, when you think of the role of transplant over the last 30 years, just think of a ladder. Think of the fact that with every round of induction chemo you get, you're up about 3, 4 rungs on that ladder. This is not low dose chemo. You're up there 3, 4 rungs high. But now we take you up to rungs 5, 6, 7 high. And by doing that, we're literally, blood counts will come down. They won't stay down unless we literally reseed. Transplant process is a reseeding. I always tell parents when I'm sitting there talking about transplant to literally think of weeds in a lawn. And as I said, we're not plucking up the weeds with that little metal prong thing. We're not spraying them with Roundup. No, if you do that, you break the roots off, and the neuroblastoma still comes back. No, we just give high dose chemo, take out the entire lawn, and then reseed. There have been multiple trials since Kate Mathey's landmark trial, CCG 3891, run in both Europe, in Japan, Korea, United States, North America, within Children's Oncology Group, that have now all shown the benefits of doing a autologous stem cell transplant as what we call a consolidation after induction chemotherapy. I always think of neuroblastoma, for the parents listening, I think of neuroblastoma therapy right now in blocks, 3 blocks of therapy. The first block is induction chemo, and that's to get the disease under control. Right now, within the Children's Oncology framework, it's 5 courses of chemotherapy. The second block of therapy is called consolidation. Within the Children's Oncology Group framework, that's 2 tandem transplants 6 weeks apart, followed by radiation to what we call primary disease. And then the third block within the Children's Oncology Group framework right now is maintenance therapy, which parents now know as immunotherapy, where they get that antibody therapy. So as a parent, think of neuroblastoma therapy as 3 blocks. The first block takes about 6 months to go through. The second block with the tandem transplants and radiation takes about 6 months to go through. And that third block with the antibody or immunotherapy takes about 6 months to go through. From start to finish, if you're looking at this as a race, it is a marathon race. It's about 18 months from start to finish. What we're really doing, though, and what we've learned with neuroblastoma is that this is an incredible tumor. We need all modalities to try to beat it. So thus we have high dose chemotherapy during induction. We have even higher dose chemotherapy during transplant. We bring in radiation. We bring in surgery after the 4th cycle of induction chemotherapy to take out the bulk tumor. We bring in antibody therapy at the back end. We literally bring in all aspects of modern oncology therapy to try to confuse this tumor and to try to get rid of it. The first goal that's been used over the last 30 years was to use transplant as a platform for high dose therapy, high dose chemotherapy, higher doses of chemo that we could ordinarily give, and then the transplants are rescue, reseeding. Where I view transplant going, the second goal is going to be as a platform for giving novel cells, for giving novel targeted therapy back to patients. This could be a whole nother talk, but a number of programs around the country are giving what are now CAR T cells or NK CAR cells. These are specific T cells, specific type of stem cells that are grown in a way to target a patient's own neuroblastoma. They're hired killers, cells that are just designed to target just neuroblastoma. This is what I view as potentially the platform for stem cells in the future, to be using stem cells, to be using T cells. T cells are immune surveillance cells in our bone marrow, to be reprogrammed to target just specific proteins on the neuroblastoma, and then to give those cells, stem cells, T cells, back to patients to target their tumor. Why do I say that's the future? Because I think we're starting to see that transplant can only take us so far. We're also starting to see, as many of the parents out there who listen to this are aware of, if they've been through transplant, all the side effects of transplant. You know, it's not for the meek of heart, both as a patient and as a caregiver. The side effects, the toxicities of the current transplant as we do it now, this high dose chemotherapy, they're real. The mouth sores are real. The potential for other organ complications is real. If you're a parent that's been through transplant and know about some of these terms, TMA, VOD is irritation of the liver. It's real. And as parents said, as one parent told me, they said, Dr. Yanik, you told me that they'd have sores in their mouth and potentially sores in the intestines. I didn't realize that these sores could go from cheek to cheek. And thus, right now, we're looking for ways to actually optimize how transplant works while minimizing all the short-term acute complications and long-term downstream complications. And thus, to give you a 10-minute answer to a short question, what are the goals for transplant? The first goal has already gotten us to where we are, to approximately a 60% disease-free survival, where we use transplant as a platform for high-dose therapy. But the future goal is to get that 60% up to 100%. And now it may be where we use these bone marrow cells, stem cells, or T cells to use them to reprogram them to be specific targeting agents to target a child's neuroblastoma. The typical workup for stem cell transplant, I'd say, is as follows. One, to assess the patient's disease status. Two, to assess their organ function. And three, to think of something that you probably haven't thought of as a parent, to serve as an educator role. And I'll walk you through each of these. So, one, to assess the disease status. We do have cutoffs in terms of the amount of tumor, we call it tumor burden, that will allow in order to start the stem cell transplant process. Transplant can only kill so many neuroblastoma cells. If we start with too high a disease burden, with transplant, we want to go from this much tumor down to this much. If you start with way too high a burden, we may go from this much to this much. And then by the time you're recovering from transplant, it's already growing back. So there are cutoffs that we use for determining disease status. Some of those cutoffs may be based on bone marrow aspirate and biopsy results. They may be based on scans. One of these scans are an MIBG scan. Oftentimes, many oncologists, myself included, will determine what's called a Curie score. And that Curie score is what we call a semi-quantitative, meaning it's not an exact number per se, but it gives us a rough idea of the tumor burden that a patient has going into transplant. And each of us has our own cutoffs for what Curie score levels we take into transplant. There's a little art of medicine about this in terms of Curie scores and at what levels different centers will take. I'll look at MRIs of the patient. Certainly, I get nervous as a transplant physician if I do an MRI of the brain and I see that there's tumor inside the brain. I get a little nervous. Is this really the optimal patient for transplant in terms of the ability of the transplant chemotherapy to even get into the brain? So one of the first things we do in terms of working up a patient is to assess their disease status in their bones, in their soft tissue, including the brain, in their bone marrow, and then try to come up with some measure to give it a grade or a score. It's more than just Curie score. It can be what we call INRC. This is International Neuroblastoma criteria for response. Does a patient meet criteria for complete response, partial response, mixed response, stable disease, progressive disease? I think most neuroblastoma physicians, transplant physicians would agree that going to transplant with progressive disease is not optimal. It's not wise. It's not something that we would do here at our center. And I think most transplant physicians would agree with me. Conversely, patients who have complete response with induction therapy are great candidates for transplant. Patients who have a partial response are also very good candidates. It's kind of when you get into that middle zone of those patients who have stable disease at the end of their 5 rounds of induction therapy. And then there's where the art of medicine comes in terms of determining, looking at other factors too. And here's some of the other factors. In fact, I always tell patients when they come into transplant, I want to see 2 feet on the ground. The first foot is I want them to be in remission or as close to remission as possible. That's 1 foot. The second foot is I want all organs working. All right. I want no active infections. We check out prior to transplant heart function, kidney function, and we certainly look at liver function, lung function. I believe every patient coming into transplant should have what's called a GFR test. That gives us an exact number of how well their kidneys are working. In fact, we kind of base our chemotherapy for transplant off that GFR test. Same thing with the heart function. Every child coming into transplant should have an echocardiogram and certainly an EKG to get some idea of how well their heart is pumping and working overall. Every center will have what are called clinical practice guidelines. Clinical practice guidelines are not standardized across centers in North America or Europe. Each center will have their own clinical practice guidelines, which will state that a patient's lung function must be at this level, their kidney function must be at this level, their heart function must be at this level in order for transplant to proceed. Our center has our own guidelines, but our guidelines may vary a little bit from what other centers may have too. So when you want to go into, when you ask, what do we do in part of the pre-transplant workup? The first thing we do is to make sure that patients have 2 feet on the ground. What's their disease status? Are they in remission, close to remission? And how well are their organs working? You want to have both feet on the ground. If a patient comes in with hopping with only 1 foot on the ground, it's going to be a tough transplant. Meaning if they come in with too much disease but good working organs, that'll be a tough transplant to get them, to get that disease burden down. If they come in with a low level of disease but marginal working organs, that transplant's going to be dang tough. We want both feet on the ground. As a clinician, we typically devote 50% of our time to taking care of our patients, with the other 50% focused on educating our patients and obviously their caregivers. It's during this pre-transplant workup that I believe strongly that the education process comes in play. When a child goes through transplant, we as the transplant physicians, we're not in the room 24/7. The nurses may be in and out, the physicians may be in and out, but it's the caregivers that are there typically 24/7. So we have to teach a parent, a grandmother, an aunt, uncle, whoever is going to be the main caregivers, to be our eyes, to be our ears, to watch that when they're there watching that child. So it's our job. We owe it to you as parents to educate you so that you know going into transplant exactly what you should be watching for, looking out for, so that when we come in, hey, Dr. Yanik, Billy is doing this, Susie is doing this. I remember prior to transplant, you said we have to watch out for this. It's our job to educate you as a physician, for us as physicians to educate you as the caregivers. We have to give patients realistic milestones. We have to give them realistic expectations. We have to tell them not just what they're going to face during transplant, but we actually have to show them those 3 steps that I talked about of neuroblastoma therapy. The first, I talked about 3 core parts: induction, consolidation, and then the immunotherapy. We have to show how transplant fits in to those 3 compartments. and what's going to happen after it. I can't just get myopic and say, we're going to do 2 transplants 6 weeks apart. Now I have to show the rationale to parents where those transplants fit into the overall scheme of therapy. When we'll do transplant, when we won't consider transplant. If we won't consider transplant, will we do a bridge and come back to transplant? I got to be able to walk patients through it right from the start. The difference between an allogeneic and an autologous transplant depends on the donor source. So with an allogeneic transplant, the donor is somebody else. It'd be as if I were donating my bone marrow to the patient. With an autologous transplant, the term auto means self. With an autologous transplant, you're donating to yourself. Okay. So we're taking out your own stem cells. By the way, you'll often hear me maybe on this talk, or if you ever talk to me in the future, use the term bone marrow cells, stem cells as interchangeably. So with an autologous stem cell transplant, autologous bone marrow transplant, we're taking out the patient's own stem cells and then giving them back in that reseeding process. There have been multiple studies, or I shouldn't say multiple, but there have been several studies looking at comparing allogeneic transplants in neuroblastoma to autologous transplants with no advantage seen with the allogeneic transplants to date, in part because there are many more complications with allogeneic transplants that aren't seen with autologous transplants by using a donor that's different than self. So over the last 30 years, the standard has been to, in North America and Europe and Asia, has been to use a patient's own bone marrow cells, their own stem cells, in that reseeding or transplant process over a different donor's cells, which would be an allogeneic transplant. We prefer to harvest the cells typically after the second or third round of induction therapy. And it almost becomes a Goldilocks in the 3 bears type situation. If we harvest the cells too early, let's say at the time of diagnosis, we're likely to not only be harvesting stem cells, but there's a good chance we could also be harvesting, collecting tumor cells. The last thing we want to do for a patient is give them back their own tumor. On the other hand, every one of us who's done transplant long enough knows that if you wait till after 4, 5, 6 rounds of induction chemotherapy and try to collect stem cells, so that bone marrow has been so beaten up with that multiple rounds of chemotherapy that you're unlikely to get enough stem cells to use for transplant. And thus the Goldilocks and the 3 bears analogy. If you harvest too soon, there's a chance you may harvest tumor cells. If you harvest too late, there's a chance you may not get enough stem cells at all. So we've kind of learned that the optimum sweet spot is typically after the second round of induction therapy or after the third round of induction chemotherapy. By then, you've minimized the risk of collecting tumor cells, but you haven't beaten up the bone marrow enough that you still can't get enough stem cells. There have been situations where we collected after the 4th round of chemotherapy, and it can be done, but again, with every boxing, I kind of view it like boxing. With every boxing round, that bone marrow gets a little more beaten up. If it gets knocked down, it gets up from the canvas a little slower, a little longer, a little harder to get back up. So the optimal time to do the harvest is when we feel that the risk for harvesting or collecting tumor cells is low and the likelihood of collecting enough stem cells is high. And we just know from experience that's typically after the second or third round of induction chemotherapy. Curie Score is a tool. It's a model. It's, for every parent listening, I would say this. It's not the only factor that should be used in considering if transplant should be done on your son or daughter. It's just a tool to help us as transplant physicians and as oncologists determine if we feel that this child is ready to go to transplant. But it's one thing that we consider. I said that in one of my earlier questions or answers, I stated that you want to have 2 feet on the ground to go into transplant. One foot being a low enough, a good disease status, a low enough tumor burden. The other foot being good organ function. So Curie score is one of those fingers that we look at to evaluate disease status. And here's what it means in English. A Curie score is based off an MIBG scan. Every patient going through neuroblastoma therapy at some point has had an MIBG scan. 90% plus of patients at the time of diagnosis will have tumor that actually lights up on an MIBG scan. The way a Curie score works is that we'll divide the body into 10 segments. At least this is how we do it in North America. We'll divide the body into 10 segments. 9 segments are different skeletal regions, and 1 segment is what we call soft tissue or organ involvement. And then we'll actually look to see how much lights up on the MIBG scan in every one of those 10 segments. We give the scores for each segment 0 to 3. 3 being basically the entire segment all lights up with disease in it. 0 being nothing lights up. So let's say the head. So we look at the head as 1 segment, your skull. If there's 1 spot on the cheekbone that lights up, it would be a score of 1. If the entire skull lights up, that'd be a score of 3. What am I walking you through? Well, I'm walking you through how we do Curie scoring. We'll divide the body into these 10 segments. We'll score each segment 0 to 3. And thus, if you do the quick math, if you have tumor in every single segment, the highest score you can be is a 30. And if you're in complete remission, then every segment is a 0 and your score is a 0. The typical patient at the time of diagnosis will have scores of 15, 20, 25, 28 per se. I do look at the score at the time of diagnosis. A lot of parents will drop their head or drop their eyes, think, oh, geez, my son has a Curie score of 23 at diagnosis. That to me isn't as important as what's the Curie score at the end of that 5 rounds of induction therapy, that first cassette of therapy. So it's not so much the Curie score you have at the time of diagnosis that matters. It's the Curie score that you have as a measure of how well your tumor has responded to your initial 5 rounds of induction therapy that matters. There's been multiple reports on what that level should be. And every physician will actually have a different cutoff in their mind. Our own group here at the University of Michigan and within the Children's Oncology Group published back in, I think it was initially back in 2012. We actually published the efficacy or the role of Curie scores in single transplants. So if you're just doing 1 transplant. And with that, the optimal Curie score was a Curie score of 2 or less. So that you wanted to go into a single transplant with a Curie score of 2 or less. We then validated that in a large European trial and published this in 2018. Again, that a Curie score of 2 or less at the time of transplant was optimal for having a good response. Meaning you've now gone through induction therapy, you started with a score of 15, 20, 29, 30, whatever, and did you get down to 2 or less prior to transplant? And that's what a lot of parents hear. We want to get down to a score of 2 or less. For full disclosure for parents listening to this talk, all that work, our first publication, and then our second one that validated in 2018, was done with single transplants. My good friend and colleague, Carrie Strebe at Ohio State, and we just published recently in 2023, the optimal Curie score in tandem transplants. We're now doing tandem transplants pretty uniformly for patients, at least within North America. For patients who have tandem transplants, the optimal Curie score going into transplant isn't a Curie score of 2 or less. It's 0. In fact, you don't even need to do a score. You just look to see if the scan's still positive or not. Okay. I don't want to oversell the data to you as parents. If your son or daughter doesn't have a Curie score of 0 at the end of induction therapy, it's not like they shouldn't undergo transplant. the optimal Curie score when we did our statistical analysis was 0. If you wanted the best outcome, have a Curie score of 0 going into transplant. However, it didn't mean that patients who had a Curie score of 1 or 2 or 3, that all was lost. No, they just didn't do quite as well going into tandem transplant as those that had a Curie score of 0. And as a parent, I guess you could ask me, at what level at the University of Michigan would you absolutely not do a transplant? Well, what you'll see is this. Just watch my hand. If you have this level of outcome with a Curie score of 0 going into tandem transplant, if it's a 1 or 2, maybe the outcome is a little lower. But as you start getting to a Curie score of 5, 6, and above, and going into tandem transplant, now the outcomes of transplant really start dropping off. This is where the art of medicine comes in. At the University of Michigan, we'll still take patients into transplant who have Curie scores obviously of 0, 1, and 2, maybe even 3. But as our patients start getting closer to a Curie score of 4 and 5, I really start thinking, maybe we should do some bridging therapy to try to knock that Curie score down to a lower level, 3, 2, or 1, or 0 if possible. Every center will have their own art of medicine for what Curie score they'll take now in this tandem transplant era. So if you hear that your son or daughter doesn't have a Curie score of 0 going into transplant, it's not the end of the world. It just means that when we did this pretty extensive statistical analysis, those that had a Curie score of 0 obviously ultimately did the best. If you have a Curie score of 1, 2, maybe even 3, it's not like it's that bad either going into tandem transplant. But I would caution for anybody listening, just having seen all these Curie scores, I would caution anybody going into transplant with a Curie score of, say, 5, 6, or above. It's like, we just couldn't do it at our center. Maybe other centers would do it, but we just couldn't do it. I think one of the, I mentioned a landmark article during one of the initial questions you had for me was Kate Mathey's article that was published in 1997 in the New England Journal of Medicine that compared transplant to extended chemotherapy. It gave the platform or the foundation for what we now do with transplant as consolidation therapy. Other landmark articles transplant-wise, certainly Julie Park's article that was published in the Journal of American Medical Association in 2019. This was the Children's Oncology Group's randomized clinical trial that compared single transplant to tandem transplant as consolidation therapy, showing a pretty clear-cut winner in those patients that were receiving the tandem transplant over the single transplant. And though every parent who's been through tandem transplant will kind of like grimace their eyes, groan with the potential side effects of transplant, to this day, tandem transplant still provides, at least with the backbone that we use, Cytoxan thiotepa for the first transplant and carboplatin etoposide melphalan for the second transplant. That tandem transplant platform still provides the optimal outcome for our patients, at least within Children's Oncology Group. So that's the second article, landmark article I give you. A third landmark article is Alice Hughes' article in New England Journal of Medicine in 2010 that established the role for antibody therapy. This antibody therapy is now given to all patients after transplant and radiation therapy. We call it immunotherapy. But there's another article that I'd like people to look at if you're watching this. Ami Desai at Northwestern in 2022 published in the Journal of Cancer. A really good article that I think deserves more publicity than it gets. And Ami actually looked at what was the best post-induction therapy for patients with high-risk neuroblastoma in those patients that had Curie scores that weren't 0. Okay. And what Ami did is she broke her patients down into 3 cohorts. And this is all based off Children's Oncology Group data. And cohort 1 was a group of 123 patients, I think it was, that said, all right, we don't have progressive disease. We've got a partial response or stable disease. And let's just go right to transplant, regardless of what the Curie score was. Group 2 was you had a partial response or stable disease. So you had a Curie score of something. It's not going to be 0. And he went on to get bridging therapy and then still went on to get transplant. And that was roughly 50 or 51 patients to my recollection. And then the third group that AMI looked at were patients that said, all right, we've got a partial response to induction therapy. We've got stable disease. By the way, stable disease to a parent, what that means is basically what you came in with is close to what you end up with at the end of induction therapy. So the third group in AMI's study were patients that got bridging therapy, but then never went on to get transplant. So what did she find in this publication? Again, I view it as a landmark publication. Well, she found that the third group didn't do well. That patients who got some type of bridging therapy but never went on to get transplant had inferior outcomes over the first two groups. Again, the first group just went straight on to transplant. The second group got some bridging therapy and then went on to transplant. The point being that for patients that have a Curie score that's over 0 at the end of induction therapy, getting transplant was still a benefit. Ultimately, if you looked at patients that had stable disease at the end of induction therapy, the group that had the highest benefit, or had the best outcome, were those patients that had bridging therapy of some sort, followed by transplant. I keep using the term bridging therapy. I view it as a detour to transplant. You're here, you finish induction therapy, you got to get to here to transplant, so you do a transplant detour. Now, the two typical means for bridging to get to transplant that we've used as investigators around North America is either chemoimmunotherapy, in which case chemotherapy is combined with a monoclonal antibody, an anti-GD2 monoclonal antibody, or MIBG therapy. MIBG therapy, many parents will know, is that radiation-targeted therapy for the neuroblastoma. So I think the key that parents should know listening to this is that, yes, if you have a Curie score of 0 at the end of induction therapy, definitely everybody in North America, Europe, I'm sure, would feel the same way, go on to transplant. For those that have a Curie score above 0, you know what? Even if it's 1, 2, at least at our center, even 3, we're likely to take you to transplant. If you have a score that's higher than that, we would advocate bridging therapy of some sort to get you down to a level that we could then take you to transplant. That bridging therapy may be chemoimmunotherapy, and maybe MIBG therapy. I always like to quote Woody Allen. Woody Allen once said that 85% of success is just showing up, meaning that if you've got a high, elevated Curie score at the end of induction therapy, 85% of success is just showing up. Do something, okay? Don't just sit there, do something. And the two main options is chemoimmunotherapy for several cycles. Oftentimes at our center, we'll give 2 to 4 cycles of chemoimmunotherapy and then relook at the Curie score, disease status, or we'll do MIBG therapy, and then if the Curie score comes down, then we'll go to transplant. It's not the be-all and end-all for deciding if you should go to transplant. It's a tool. And if your child doesn't have a Curie score of 0 going into tandem transplant, it's not the end of the world, okay? It's just a tool, okay? How do I present different options to parents? I start by making sure that they trust in what I'm about to say and that I trust in what they're asking me back. And once I can see that that trust is there, then we can start talking pretty frankly about things. Any parent who's been through a transplant consult with me will know that I can be pretty blunt at times in terms of saying, here's the best odds I think we can get. I don't believe in sugarcoating things sometimes. I don't believe in just giving everybody an optimism bias. But the one thing that I love about our program here at our center is we don't always just give patients or caregivers an optimism bias. We give you a compassion bias. And that's what I think that all parents and patients deserve, is a compassion bias. Once they see that in us, and we truly care about the care we're giving, now we can present the options to them. how do I decide what's the best option? I think as a parent, you would smile knowing that there's a large brotherhood of oncologists, and it is a brotherhood. I have many oncologists that work with neuroblastoma on my cell phone, their cell phone numbers. I email people every week, maybe not every day, but at least every week, I'm emailing a different oncologist around the country about some neuroblastoma issue. They're emailing me. It is a band of brothers in terms of physicians. Whenever I send out emails to my colleagues, I always start it with 3 words, actually 4 words, to my neuroblastoma amigos. We literally call ourselves the neuroblastoma amigos. And it's a band of brothers, of physicians that truly care about what you as parents, what you as a child, as an adolescent are about to go through for your neuroblastoma therapy. So when we go to present the potential options to you, it often means that we've discussed it not only internally within our own group. All transplant teams have internal discussions. They have meetings typically weekly or more to go over patients coming in to weigh the options internally. But we've oftentimes discussed the options externally with our colleagues outside of our own group. You already heard me say that some of our closest colleagues at Ohio State, but we've got really close colleagues at, I just start naming the centers, CHLA, Children's Hospital of Philadelphia, at Dana-Farber. The list is endless almost. Even within our state, the Detroit Medical Center, the Children's Hospital of Michigan in Detroit, at DeVos on the west side. We're literally a team. All physicians across the country. I'm even thinking of more centers I left out: Colorado, Seattle, UCSF, and San Francisco. The list is going to be endless. Emory, Cincinnati. I'm going to be guilty when I look at this and think, oh, I forgot to mention MCW, Milwaukee. Chicago, where Ami Desai is, Northwestern. We have Cleveland Clinic, Case Western. My goodness, the list is endless. And if any physician watching this says, Greg, you forgot to mention our center, I apologize. UT Southwestern, Baylor, certainly, St. Louis. What you're seeing as a parent listening to this is I know there's an extensive network of parents that talk to each other within neuroblastoma circles. There's an extensive network of physicians that talk to each other within neuroblastoma circles. So when we weigh the options and benefits for you, I think you should know as a parent that we've typically weighed it in our own minds, in our own hearts for your child, even before coming into that consult. I said that you have to have 2 feet on the ground to come into transplant. It's when a child doesn't have both feet on the ground, meaning their disease status may be a little higher than I want, or their organ function is a little lower than I want, that I'll be talking to my colleagues. Hey, what do you think about this? What do you think if we did this? What do you think if we adjusted this? What do you think if I did this, this, this? I think you would smile as a parent to know all that talking that's going on behind the scenes, both internally within a center and externally amongst centers, as we start looking at the options for your child in transplant. When you think of immunotherapy in its role, I think of 2 situations. The first situation are patients that have now gone through induction therapy and they still have a lot of tumor, or patients that have relapsed after initially going into remission. They may have even already had transplant. So I view immunotherapy as a model of hope for these patients that have had a marginal response to initial therapy or relapsed after having previously had a good response. When I mentioned Sentinel articles before, I should have included this one by Rajan Modi that was published in 2017 in Lancet Oncology. And this was a children's oncology group trial where half of the patients they had relapsed or had refractory disease, and half the patients just got chemotherapy. And the other half of the patients got chemotherapy, in which the chemotherapy was combined with a monoclonal antibody at that time being dinutuximab. What Dr. Modi published was a clear-cut survival advantage in terms of response for the group that received chemotherapy with the antibody given it concurrently. In fact, if I recollect from the paper, I believe the response rate to just the chemotherapy arm was in the 5 to 10% range, and the response rate in the chemotherapy with the antibody arm was slightly over 50%. That was a landmark publication because for us, it told us that we can now start giving hope to the patients that we previously couldn't give a lot of hope to. Those patients that had relapsed, those patients that had refractory disease. Now we had another tool in our toolbox, this combination of giving chemotherapy with antibody and starting to see some dramatic responses to that combination. So I said that there's two roles for immunotherapy. The first role is for those patients that have now completed induction therapy and they've got too high a disease burden to go to transplant, to try to use chemoimmunotherapy as a bridge to lower their Curie score, a way to lower their disease or tumor burden to get back to transplant. And certainly for those patients who have relapsed or relapsed disease, is another way to get their tumor back under control, to then potentially go on to other modalities after that. Unfortunately, I can't promise you that chemoimmunotherapy is always the answer, that I can promise cure for a child, but I can say this, it's dang effective therapy in many patients with some pretty dramatic responses we've seen over the years. In fact, right now within the Children's Oncology Group, this whole concept of chemoimmunotherapy is the platform for their current phase 3 trial. And right now in North America, if you enrolled on this is the current upfront neuroblastoma trial for high-risk neuroblastoma, patients are randomized to either get the standard 5 rounds of chemotherapy during induction, or to get these cycles of chemotherapy in which you're getting immunotherapy or antibody at the same time. So basically, half the patients are randomized for induction to just get chemotherapy. The other half are randomized, it's like a 2-arm thing, to get chemotherapy with immunotherapy during induction. And the reason for this is that we saw that chemoimmunotherapy was working so well for relapsed or refractory patients. It's like, why don't we move it up front and see if it helps our induction response rates? So that's what's being looked at right now within the COG group. That's the first role for immunotherapy. The second role for immunotherapy, I touched base on a little bit ago, that I view transplant is going to become a platform for novel immunologic methods to target neuroblastoma. Ways that we can develop not so much chemotherapy that just blankets cells that are actively growing and dividing, but to develop tumor-targeted bullets, where we take somebody's immune system and literally reprogram it to target just proteins that are on the outer shell of their tumor. How far away from doing this? Well, not far at all. In fact, right now on clinicaltrials.gov, that's the FDA's website, there's 26 clinical trials using what are called CAR T cells to target neuroblastoma. There's 21 clinical trials on the FDA's website using what are called NK CAR cells to target neuroblastoma. Basically, what we're doing is we're taking a patient's T cells or NK cells, we're taking a portion of their immune system, their white blood cells, NK cells, T cells are part of your immune system that do targeting, and we're reprogramming them to just target your tumor. How well will this work? Well, the proof will be in the pudding. Many of these clinical trials are currently ongoing in phase 1, phase 2, and hopefully soon even phase 3 trials around the country, but also around the world. Some novel immune type trials like this being done not only in North America, but in Europe and also in Asia. I think for us, it's the hope for the future. Is not that we're going to be going back to just escalating up that ladder, rungs of the ladder, with higher dose therapy for transplant. But that now we're just going to be using one particular rung that just targets just where that genetic defect or that gene defect is on that neuroblastoma, and just hammer that rung with this targeted therapy. So when you ask me what is the role for immunotherapy, I look at it in terms of two things. One being chemoimmunotherapy, where we give chemotherapy with antibodies in response to patients that have not had a great response to induction therapy or that have relapsed after therapy. And the second is to use some novel immune type mechanism to reprogram T cells, immune surveillance cells, to target a patient's neuroblastoma.